Hello guys, welcome back to one more PYT here. We are going to discuss about colon cancers. Every PYT what I'm going to discuss here will be based on Robbins pathology only because there has been a notion that Robbins is not doable, not revisable. We'll make sure every PYT will learn from Robbins and we'll make sure 100% strike rate comes from Robbins, right? If you first time here, put on a big smile and let's start learning and don't forget to subscribe to the channel, fine? So now, colon cancer or any cancer for that matter, we need to learn a few important things and that's where the questions also come from. One, the etiology. The etiology will be always into sporadic etiology and inherited or a syndromic etiology. And colon cancer is a huge list of syndrome. We'll look at every bit of it, every single bit of it required, right? And then we'll look at gross microscopy. Is there any radiological sign which is you have to remember with relation to the gross? Because if you remember gross, most of the time the radiology is sorted. And then the microscopy, IHC, and prognostic factors. This is something which you have to know for every cancer with respect to PYTs because most of the previous year questions will come only from these topics, fine? Now, sporadic colon cancer, the etiology is very simple. There are two important etiology. When you have a very high less fiber diet and a very high cholesterol or a pure carbohydrate diet, this combination is going to increase the risk of colon cancer, right? High consumption of red meat is something which is told to be one of the important risk factor in addition to low consumption of fibers. See, if you only consume red meat and fibers are good, it's not a problem. More consumption of red meat at the same time less consumption of fibers is going to be a problem. Definitely alcohol smoking is undoubtedly a contributing factor but not the main etiological factor. High fiber diet, low fiber diet and high consumption of red meat is one of the important risk factors of colonic tumors. When you come to inherited, there's a huge list of syndromes and these are all these syndromes with from Robbins. It might look big but I'll tell you exactly what to remember, fine? So juvenile polypo syndrome, this INICT also this question came, if you guys remember, the mutation is SMAD4. Don't need not remember this. If you want to remember bone morphogenic proteins and TNF beta signaling pathway. But SMAD4 is the gene involved in juvenile polyposis syndrome. Juvenile polyposis, remember one important finding: the most common site of juvenile polyp is rectum. Is a sporadic one is rectum. Polyposis can happen anywhere. In addition to the polyps, most of the syndrome have extra intestinal manifestation. One of the important thing here is congenital malformations and clubbing. Do remember this? That's one of the important extra intestinal manifestation of juvenile polyps, right? I'll give this PDF to you in the Telegram channel. So you have increase of polyps, gastric cancer, small intestinal colonic, and pancreatic cancers also. Fine. Then we have Peutz-Jeghers syndrome. You know that Peutz-Jeghers syndrome, again the most common site is going to be jejunum. If it's a pure Peutz-Jeghers polyp in syndrome, it's again it can happen anywhere. So the important gene here is STK11, right? It also has one more name, right? LKB1, STK11 or LKB1 the gene, and it's a kinase pathway related. One important thing you should never forget: arborizing polyps, classical hallmark of polyposis, your Peutz-Jeghers polyp, and one of the important cancer is pancreatic cancer. Pancreatic cancer and Peutz-Jeghers is like this. The risk is about 50 times, 100 times risk of pancreatic cancer. And obviously, other intestinal manifestations you will definitely remember. Pigmented papules will be there, right? Like I said, it's very, very, very important pancreatic, right? The oral pigmentation, classical finding of Peutz-Jeghers syndrome, right? Next. So we have multiple names for this. Cowden hematomatous, Bunyan-Rayleigh syndrome, all of them. All these have been replaced now as P10 hematomatous syndrome, right? All of them are being used the name P10 because the common thing which is muted here is P10 gene, a tumor suppressor gene, and PK3 pathway, fine? Okay, you have multiple hematomas, intestine, nothing much to remember. As of now date, you have not got any MCQs in the extra intestinal manifestation, but do remember, it's something which can also cause more and more and more hematomas. Inflammatory polyps might be there, but one of the important things you can see is there's no increase in GI cancers in this patient. That's a very interesting observation here. It's a polyposis syndrome, hematomatous syndrome, very less chance of an colonic adenocarcinoma, fine? Okay, now chronic Canada syndrome is non-hereditary. One of the polyposis which is not inherited is chronic Canada syndrome. It's not inherited. Again, you'll have the same hematomatous here. In addition to that, you have good amount of nail atrophy, pigmentation, cachexia, everything can be there. Though it's not inherited, it's a bit more fatal and a little more aggressive than any other syndromes what you have read. Fine, that's one. Okay, tuberous, I'm not going to discuss much here. Not primarily a colonic lesion, but yes, in tuberous also you'll have multiple hematomas. It's more discussed in the CNS tumors and others. Fine, FAP. FAP has different variants. That's very, very important. Classical FAP, attenuated, less aggressive FAP. I need minimum of 100 polyps in classical FAP. If you have somewhere around 30 polyps, that's enough for me to call it an attenuated FAP, right? So this attenuated FAP, classical FAP, and the modifications of FAP, Gardner-Turcos are also FAP. Look at that. All of them are APC gene only. This classically explains two important genetic things: your incomplete penetrance, attenuated, not complete, variable expressivity, not just polyps, multiple other places, right? Gardner Turcot, most of them are required. Turcot is related to your CNS, right? Okay, medulloblastomas, glioblastomas, and Gardner is related to your skin and bone. Remember, like gardening person involves the skin and a little bit maybe in the bones, osteoma, something of that sort, right? Now, osteomas, desmoid tumors, skin tumors will be seen in gardening person, so Gardner syndrome. Just a stupid way to remember, that's it. And Turcot, you'll have the CNS tumor along with the colonic polyps. All of them will have multiple colonic polyps. You need not remember any other example for incomplete printers and variables in expressivity. Classical places, right? Okay. So these are all syndromic thing. But I will not complete it without talking about FAP versus HNPCC. Right? So these are the main syndromes or the main pathogenic pathway by which colonic cancer comes. So I have a normal colon. When I have a simple adenoma, it's most likely related to FAP thing, which will definitely move to colonic cancer. So we call it an adenoma carcinoma sequence. The same thing happens in FAP and your beta catenin. That's your APC and beta catenin pathway mutation, right? The same thing can happen in case of an HNPCC also. See, HNPCC, hereditary non-polyposis. It will not have multiple polyps like FAP, not like hundreds. Yes, 5, 10 of them can be there, right? It will have polyps, but not polyposis. Not the extent to call it polypose, right? HNPC has a defect in mismatch repair. It's actually a mismatch repair defect. So when you have a mismatch repair defect, so what happens here is, here the DNA repair is not very good. If the DNA repair is not very good, can I say whenever cell divides very fast, there's a chance of them to have a mutation because the repair is not good? Obviously. I have two types of colon, right side colon and left side colon. Right side colon has more of absorption, villi. Left side colon is more of compaction of the stool, not much. So right side will have more villi, left side will have less villi, just for assumption. So can I say right side will have more multiplication, division, more dependent on the repair pathway? Yes, that's the reason HNP will have predominantly right-sided lesions. There's an MCQ, never memorize, never ever memorize with me, right? It's concepts. So when I have a repair pathway, it'll defect in the repair pathway, I'll have more problem when there's more cell division. More cell division happens in villi, and the villi are more common in the right side because it has more absorption. That's all, right? HNPC, one more important thing which can come in future exams, it has not been asked till now. So I have a precursor lesion, not called as an adenoma, we call it an serrated adenoma. This is very, very important. The precursor region of an HNPC pathway or a methyl mismatch repair defect pathway is serrated adenoma. Obviously, that also will go to colonic carcinoma only. The reason why it's called serrated is the tumor, when you look, it look like this. It'll have serrations. It's like a villus adenoma only, but it'll have serrations on the side, so we call it a serrated adenoma. And more important thing is, in case of HNPC related cancer, in microscopy, you'll have more and more and more lymphocytes. That's a clue to say that, okay, it's something related to HNP related cancer, fine? These are two pathways which you should never ever forget in relation to your colonic tumors. Now let's come to gross. Like any other tumor, what happens is, gross will have, let's assume this is a colon. So I'm going to have ulceroproliferative lesion. That's how it will be, right? So if it proliferates, see, it's a three-dimensional structure. It's going to proliferate throughout, right? If it proliferates like this is what is going to give this image. If you do a barium enema or something, apple core lesion. The same thing is also called as napkin ring. It looks like this. Imagine this is a napkin and the ring is constricting them, right? This is a napkin ring, right? So this gives the napkin ring appearance or your apple core nodule in case of an imaging pathway. This looks like an apple core. Centers. You bite an apple on the sides, you just leave the top. It looks like an apple core. When you do use a barium imaging, right? Same finding. It's nothing but the ulceroproliferative lesion. That's all. One clinical manifestation I never ever want you to forget. It's related to hematology. This ulceroproliferative lesion will have an occult blood loss. Because of this occult blood loss, most of the time the symptom will be an elderly patient with an IDA. Elderly patient coming with an iron deficiency anemia, always think of a colonic tumor, most likely an occult blood loss due to these tumors. Fine, very little blood loss, like 0.5, 0.2 ml per day. throughout the year, definitely can have iron deficiency anemia, right? Perfect. Got it? Now let's go to the final leg of the today class. Microscopy, glands plus dysplasia plus invasion, it will not change. It's an adenocarcinoma. Like I said, you'll have more lymphocytes in of HNPC related, otherwise I won't have. These two are already known IHCs, CK20 and CDX2. CK20 is a marker for anything in the lower GIT. Anything below the ligaments of trees, adenocarcinoma, marker is CK20. CDX2 is also a marker. These are two new markers. Especially if you're preparing for INICD, remember them. SAT-B2. Okay, it's SAT-B2. It's a marker for this and also osteosarcoma. HLA-G again is a very new marker for recurrence prediction. If HLA-G is positive, in case of microscopy, there's a very high chance of recurrence in that adenocarcinoma. Remember, especially if you're preparing for INICD, this might come in handy for sure. And prognostic factor, two important things, words from exactly from Robbins. Depth of invasion, that's your T stage. Presence of lymph node, that's your end stage, right? That's what is going to predict the outcome of colonic cancer, in addition, obviously, to the uh, extent, obviously, to the response to the therapy and everything. Fine. Okay, that's all for today. I'll put the links of the Telegram channel, Instagram channel, wherever you're comfortable with. I'll put the notes also in the Telegram channel. I want you guys to read every day, attend the quiz in the evening, so we'll get through one PYQ a day till the need PG. So everything related to pathology will be sorted. Fine. See you soon. Bye bye, guys. Enjoy your life.